Good morning. Welcome to our Grand Rounds presentation for today. We are with groups 27 and 28. Special welcome to our online viewers as well. Just a brief history about the Grand Rounds here at KCU is that this is a panel of first-year medical students that are armed with anatomy and basic clinical sciences up to this point. They receive cases from Massachusetts General Hospital that are published in the New England Journal of Medicine. So they review these cases, and this is a self-taught process. So this really makes the group and the formal presentation a very wonderful and exciting thing. After the presentation, we will be open for questions. Please feel free to submit them online or to present them here up at the front. And without further ado, let's turn it over to the groups.
Good morning. Good morning. My name is Blake Westling. We are Group 27, and we'll be presenting Case 7 from the 1998 case records of Massachusetts General Hospital. Our case is a 74-year-old man with dementia, Parkinsonism, and an insular lesion. These are the members of our group. I will begin by discussing the patient history and presentation to the clinic. Our patient is a 74-year-old right-handed man with a history of an irregular heartbeat. He was previously diagnosed and treated for a pleomorphic adenoma of the parotid gland. Current medications at the time of admission included buffered aspirin and a proprietary antioxidant mixture. Our patient was highly educated and had attended graduate school. He was retired from his profession and had a 10-year PAC history. He also drank a small amount of wine nightly. Family history included a sister who had Parkinsonism. At 52 months prior to admission, the patient experienced depression with prominent fatigue and sleep perversion. He experienced severe anxiety and was administered amitriptyline, an antipsychotic. This was discontinued because it caused drowsiness and confusion. At 33 months prior to admission, our patient experienced memory defects and could not calculate the tip at a restaurant. According to the patient's family, he became disoriented and had attention deficits. A neurological examination was performed. Our patient drew a clock poorly and recalled only 2 of 3 items at a 5-minute interval. The patient scored a 24 out of 30 on the mini mental state exam. The mini mental state exam awards patients points for answering questions, problem solving, and performing memory recall tasks. One of the benefits to the mini mental state exam is that it can be scored according to educational level. Because our patient was highly educated and had attended graduate school, a score of 25 or above would be considered normal. Because our patient had scored a 24, this was considered abnormal and additional tests were performed. Routine laboratory tests and MRI were both normal at this time. Doxepin was administered without benefit. At 16 months prior to admission, the patient stated that he could not recall the days of the events of the day and had to supplement his memory by writing events down. He became disoriented and could not recall any of the 3 items at a 5-minute interval. Additionally, he drew a clock incorrectly. A small amplitude postural tremor was present that persisted as dysmetria upon finger-to-nose testing. At 10 months prior to admission, the patient experienced awkwardness on the left side of his body, and his handwriting became sloppy and smaller, although he was right-handed. He stopped playing tennis and golf and had difficulties with activities of daily living, such as buttoning his clothing. He had diminished facial expression, slowed movement, and a shuffling gait. At 5 months prior to admission, the patient had an emotionless stare, decreased spontaneous movement, and end-block turning. At this time, he scored an 18 out of 30 on the mini mental state exam, and this put him in the mild cognitively impaired category. The patient presented to the clinic with a progressive motor and cognitive difficulties, a postural tremor persisting on finger-to-nose testing, and experienced floored visual hallucinations while in the hospital, at one time noting that he saw a beautiful peacock sitting on the windowsill. In recent months, he had lost over 5 kilograms of weight. Physical examination revealed a temperature of 37 degrees Celsius, a pulse of 118, and a respiratory rate of 20. Blood pressure was 130/70. A full neurological examination was performed at time of admission. He was alert but disoriented concerning his age, the season, and the month. He drew a clock incorrectly and could not calculate the number of quarters in $1.50. Fluency, repetition, and comprehension of objects was all normal. At this time, he scored a 13 out of 28 on the Blessed Dementia Scale. The Blessed Dementia Scale assesses a patient's ability to perform daily activities of living, habits, and personality changes. He had diminished facial movements on the left side, an expressionless face with a slightly asymmetric smile, and continuous twitching of face, arm, and leg musculature. His voice was hypophonic and monotonic. Visual fields were intact, cardinal gaze was full, and saccades were normal. Our patient had difficulty suppressing blinking upon glabellar tapping, had slight cogwheel rigidity in both wrists, and supination and pronation were awkward on the left but performed normal on the right. Our patient also experienced frequent myoclonic jerks in the arms and the legs. He had a shuffling gait with reduced arm swinging and slight end block turning. Deep tendon reflexes were brisk but slightly diminished at the ankles. Babinski, grasp, palmomental, and snout reflexes were all present in our patient. Graphesthesia was poor bilaterally, however normal motor strength testing persisted. Several tests were performed upon admission. Lab tests including urine, prothrombin, partial thromboplastin, and TSH levels were all normal. An MRI scan revealed a right insular lesion. And a PET scan using fluorodeoxyglucose showed no increase in uptake at the site of the insular lesion, but a slight decrease in uptake in both parietal and frontal lobes. Upon admission, an EEG was performed that showed generalized slowing from 4 to 7 Hz and 50 to 70 microvolts without focal features. The single spike in the temporal region occurred every 15 to 30 seconds, more often on the left. I will now turn it over to Luc Wazoun to present the differential diagnosis.
I'm student Dr. Luc Wazoun, and I'll be presenting the differential diagnosis for our case. I would like to begin with a summary of our patient's symptoms, including left-sided awkwardness, progressive cognitive decline accompanied with episodic delirium and disorientation, extrapyramidal symptoms with psychomotor slowing, including dystonia, akathisia, tardive dyskinesia, and Parkinsonism. Parkinsonism can present as rigidity, bradykinesia, tremors, postural instability, as well as mask-like facies. Our patient also presented with florid visual hallucinations. MRI scans were performed on our patient. The MRI scan on the left displays the increased signal in the right insular cortex. The lesion was approximately 1.8 centimeters in diameter. Margins of the lesion were poorly defined after contrast administration, as shown in the MRI scan on the right. This was suggestive of infiltrative growth of the lesion. PET scan was also performed on our patient after administration of fluorodeoxyglucose. Normal uptake was displayed in the area around the lesion. This was suggestive of a neoplasm. Therefore, not likely a malignant or infectious pathology which would avidly uptake the glucose. Slightly decreased uptake was displayed in the parietal and frontal lobes bilaterally. This was indicative of a dementing illness. The figure on your right shows the location of the insular cortex. Any of the following could, but may not necessarily be affected by a lesion in the insular lobe, including taste, as the anterior insula is the primary gustatory cortex, self-awareness, conscious experience of emotion, as well as motor control. Our patient did present with a motor control deficit as he presented with left-sided awkwardness. A biopsy of the right temporal lesion was performed. It revealed an astrocytic tumor without any necrosis. It was diagnosed as a grade 3 anaplastic astrocytoma. This is a type of glioma that is considered high grade based on the World Health Organization classification, which uses a 4-point scale. It is a common astrocytoma that generally presents with advanced age. Surgical resection is the definitive treatment, but the location of the lesion in the right insular cortex complicates the procedure in our patient. It is important to note that although the right insular lesion did cause our patient's left-sided awkwardness, the astrocytoma does not account for our patient's entire clinical presentation, namely the progressive cognitive decline and motor deficits. We will now address some reversible and irreversible causes for the rest of our patient's presentation. We would first like to address the reversible causes before investigating the more serious and irreversible pathologies. First on our list of differential diagnosis is hypothyroidism, as patients present with vague symptoms, including lethargy, forgetfulness, and depression. Even though all of these symptoms were present in our patient, it is less likely as the patient's TSH levels were normal. Neurosyphilis shares qualities with both reversible and irreversible pathologies. It is caused by a treatable pathogen. However, most of the damage to by the pathogen in the central nervous system is irreversible. Neurosyphilis is an infection of the brain and spinal cord caused by the pathogenic spirochete bacterium Treponema pallidum. Neurosyphilis develops 10 to 20 years after untreated infection, while not everyone who contracts syphilis will develop the condition. Patients present with nuchal rigidity, abnormal gait, visual disturbances, hyperactive reflexes, depression, changes in personality, confusion, and tremors. Some individuals display no symptoms as under the asymptomatic subset. The symptoms bolded here were present in our patient. A diagnosis of neurosyphilis can be addressed with lumbar puncture as well as MRI. Lumbar puncture would reveal increased protein level and leukocyte count in patients with neurosyphilis. Our patient's lumbar puncture results, as shown in this table, display no white blood cells, as well as normal protein levels. We should note that VDLR is a procedure to definitively test for the presence of syphilis antibodies, but this was not performed in our patient. Therefore, the lumbar puncture results lower our index of suspicion for a diagnosis of neurosyphilis. We will now consider some irreversible causes and degenerative dementias. We will begin with Alzheimer's disease, the most common dementing illness in the elderly. Patients present with insidious onset of symptoms, memory loss, especially short-term memory, behavioral changes, apraxia, aphasia, agnosia, as well as altered executive function, some of which were present in our patient as bolded here. But there are no motor deficits and hallucinations present in patients with Alzheimer's. Additionally, there was no gray matter atrophy present on our patient's MRI, which is characteristic of Alzheimer's disease, and therefore lowers our index of suspicion. We will now address multi-infarct dementia. Multi-infarct dementia is dementia that presents secondary to strokes and vascular disease. Ischemia to focal areas of the brain lead to sudden onset of symptoms in a stepwise manner, impaired executive functioning, agnosia, memory impairment, visual disturbances, aphasia, asymmetric reflexes, and focal neurological signs. The symptoms bolded here were also present in our patient. Our patient has no history of strokes or vascular disease, and more importantly, a progressive, non-stepwise onset of dementia, making a multi-infarct dementia a less likely diagnosis. We will now address Binswanger's disease. Binswanger's disease is due to atherosclerosis, which causes damage to the central nervous system, as arteries in the deep white matter become damaged and lead to disease. Patients present with short-term memory deficits, psychomotor slowing, impaired executive functioning, ataxic gait, changes in personality, specifically apathy, as well as depression. Although all of these symptoms are present in our patient's MRI makes diagnosis less likely. MRI shows extensive MRI shows extensive signal abnormalities in white matter in patients with Binswanger's disease, as shown in this MRI scan. Imaging reveals cerebral atrophy with multifocal, periventricular, and white matter bright lesions. These appear on fluid attenuation inversion recovery imaging. These were not present in our patient's MRI and therefore lower our index of suspicion. We will now address Creutzfeldt-Jakob disease, specifically the Heidenhain variant. This is a human prion disease which can be either genetic or infectious. It is characterized by the accumulation of aberrant and misfolded proteins in the brain. Patients present with rapidly progressive cognitive impairment, myoclonus, extrapyramidal symptoms, florid visual hallucinations, akinetic mutism, as well as cortical blindness. The symptoms bolded here were present in our patient. A hallmark is shown on EEG with the appearance of sharp waves, as displayed on the EEG on the left. Widespread sharp waves were not present in our patient's EEG. The normal EEG, as shown on the right, shows low amplitude and alpha wave activity at 8 to 12 hertz. Local EEG spikes in our patient's left temporal region due to the neoplasm displayed slow electrical activity at 4 to 7 hertz, making Creutzfeldt-Jakob disease a less likely diagnosis. We will now address HIV type 1 associated neurocognitive disorder. We will refer to this as HIV dementia. HIV dementia occurs in 15% of AIDS patients and could be the first manifesting set of symptoms. It generally presents later in the course of the infection and is progressive. Symptoms include forgetfulness, psychomotor slowing, decreased concentration, changes in personality, specifically apathy, unstable gait, and poor coordination. All of these were present in our patient as bolded. Although our patient wasn't explicitly tested for a CD4 count or for the presence of HIV RNA, this diagnosis is less likely due to the normal white blood cell count, as displayed here, and the lack of evidence of HIV infection in the patient's history, making a diagnosis of HIV dementia a less likely cause. This leaves us with a differential diagnosis of dementia with Lewy bodies. The criteria for diagnosis of dementia with Lewy bodies is based on the 1996 Dementia with Lewy Bodies Consortium. It includes a central feature, core features, suggestive features, and supportive features. The central feature is required for probable diagnosis, being progressive dementia, severe enough to interfere with normal social or occupational function, leading to cognitive deficits, specifically in attention, executive function, and visuospatial ability. Progressive dementia was present in our patient. Two core features are required for probable diagnosis, including fluctuating cognition with related episodic delirium, recurrent visual hallucinations, as well as spontaneous Parkinsonism. All three of these symptoms were present in our patient as well. Suggestive features, along with core features, lead to probable diagnosis, including rapid eye movement sleep behavior disorder, severe sensitivity to antipsychotic medications, and low dopamine transporter uptake in the basal ganglia. Our patient did present with rapid eye movement sleep behavior disorder. Supportive features are commonly associated but not needed for probable diagnosis, including repeated falls, syncope, severe autonomic dysfunction, non-visual hallucinations, systematized delusions, depression, generalized low uptake on CT perfusion or PET metabolism, and prominent slow wave activity on EEG with temporal lobe sharp waves. The following symptoms bolded were also present in our patient. Dementia with Lewy bodies shares clinical features with both Parkinson's and Alzheimer's disease and is often misdiagnosed as one of these conditions. This spectrum displays Alzheimer's disease on one end, noted as AD, with Parkinson's disease on the other, noted as PD. Dementia with Lewy bodies is located in the center, noted as DLB. Dementia with Lewy bodies shares the cognitive characteristics with Alzheimer's, noted as memory disorder, and the motor deficits of Parkinson's disease, noted as extrapyramidal disorder. However, dementia with Lewy bodies is uniquely characterized by the additional behavioral abnormalities and visual hallucinations. If a misdiagnosis of Alzheimer's or Parkinson's disease is made, this could unnecessarily harm the patient, as certain neuroleptic medications worsen the extrapyramidal symptoms in dementia with Lewy bodies. If the diagnostic criteria are followed, such misdiagnoses should not occur. Dementia with Lewy bodies is less likely if a diagnosis of dementia occurs 1 or more years after the onset of Parkinsonism. This would be characterized as Parkinson's disease dementia. Parkinson's disease dementia is symptomatically similar to dementia with Lewy bodies. If a diagnosis of dementia occurs within 1 year of the onset of Parkinsonism, it is considered dementia with Lewy bodies. The temporal onset of symptoms is the main difference. We will now address the neuropathology of dementia with Lewy bodies. A biopsy of the frontal cortex was performed, as well as the biopsy of the insular lobe. A neuron was found associated with a round eosinophilic inclusion. These inclusions reacted with ubiquitin. This was indicative of a Lewy body. The frontal cortex biopsy, shown on the left, displayed normal neuronal density. It is important to note there was no histological evidence of Alzheimer's disease in our patient, as no tau tangles or amyloid plaques were shown on targeted staining. The figure on the right shows collections of amyloid plaques in the cerebral cortex of a patient with Alzheimer's disease. Lewy bodies are alpha-synuclein neuronal inclusions. When these proteins become insoluble, they will aggregate and be classified as Lewy bodies. Misfolded alpha-synuclein proteins are converted into pathological oligomers and higher-order aggregates that form fibrils and deposit into Lewy bodies or Lewy neurites in affected neurons. The aggregation is associated with the death of the neuron. It is unknown if the Lewy bodies are the cause or result of neuronal death. The areas of aggregation within the brain correspond to the symptoms, including the cerebral cortex, the amygdala with psychiatric symptoms, the hippocampal formation with memory deficits, as well as the substantia nigra with extrapyramidal symptoms. Parkinson's disease is characterized by Lewy bodies solely in the substantia nigra. Additionally, loss of neuronal density in the pars compacta of the substantia nigra and nucleus ceruleus is also a common feature of dementia with Lewy bodies. The anaplastic astrocytoma in the right insular lobe likely accounts for this patient's left-sided awkwardness, but not the cognitive and motor deficits. Based on the 1996 Dementia with Lewy Bodies Consensus Consortium Diagnostic Criteria, this patient likely has dementia with Lewy bodies. The diagnosis of dementia with Lewy bodies was confirmed on immunohistological staining. This is the first known occasion that Lewy bodies have been identified in a living patient. There is no known correlation between dementia with Lewy bodies and glioma at this time. I would now like to welcome student Dr. Stephanie Webby to address the treatment, ethical considerations, and patient education for our case.
Thank you, student Dr. Wizoon. I am student Dr. Stephanie Webby, and I will be discussing the treatment received by our patient, ethical considerations, and patient education. Our patient received a definitive diagnosis of an anaplastic astrocytoma and dementia with Lewy bodies. First, I will discuss the treatment of the anaplastic astrocytoma. Our patient's anaplastic astrocytoma was treated with radiation therapy. Radiation therapy is the attempt to use high doses of radiation to kill the cancer cells and stop them from spreading. The median survival rate of using only radiation therapy is 12.1 months. Some adverse side effects of radiation therapy are damage to cells that are not neoplastic, skin changes, fatigue, drowsiness, and is dependent on what part of the body is being treated. The total amount of radiation our patient was exposed to was 40 centigrade, which was administered over a 4-week period. The patient tolerated the radiation therapy well, however, drowsiness and fatigue did develop. Our patient was treated for these side effects with the corticosteroid dexamethasone to suppress the inflammation, and this was given at 2 milligrams twice per day. It is important to note that the current treatment for patients with anaplastic astrocytomas is different than it was during our patient's case in 1998. The current treatment options include a combination of surgery, chemotherapy, and radiation. A combination of these is provided on a case-by-case basis in order to produce the best treatment plan for each individual patient. The anaplastic astrocytoma surgical procedure is a gross resection that improves survival significantly. There are many goals to this procedure, including controlling the growth of the tumor and reducing symptoms associated with intracranial hypertension and focal defects. Our patient did not receive surgery due to the location of the astrocytoma being too difficult and risky to reach without harming the patient. The second therapy that is currently used is the oral chemotherapy drug temozolomide, or TMZ. TMZ undergoes rapid non-enzymatic conversion at physiologic pH of 7.4 to form the active metabolite monoethyl triazinoimidazole carboxamide, or MTIC. MTIC causes cytotoxic methylation of DNA and mismatching of a nucleotide. As you can see in this figure, here's TMZ, and it's converted to the MTIC at a pH greater than 7, and then the MTIC methylates the DNA, which causes mismatching of the nucleotide, and this will cause an increase in DNA double-stranded breaks and apoptosis. TMZ was not available for our patient in 1998 because TMZ was not FDA approved until a year later in 1999. Now we will discuss the treatment of dementia with Lewy bodies. There is no cure for this disease, and therefore the standard of care for patients with dementia with Lewy bodies is to treat the symptoms. The median survival rate is 7.4 years after onset. In regards to our patient, the only symptom that was treated was his declining mental function with the use of antipsychotics. Our patient had been experiencing hallucinations. Hallucinations are false perceptions that affect our special senses. Our patient specifically was experiencing visual hallucinations, such as seeing a beautiful peacock sitting on the windowsill. Our patient also began to have fixed delusions. Fixed delusions are described as false beliefs that are clearly implausible and do not derive from ordinary life experiences. To help treat patients experiencing hallucinations and delusions, antipsychotics can be used. However, for a patient with dementia with Lewy bodies, antipsychotics are relatively contraindicated. The reason for this is that patients are susceptible to extrapyramidal side effects that can be caused by the antipsychotics. There are two kinds of antipsychotics, typical and atypical. For a patient with dementia with Lewy bodies, it is preferred to use atypical antipsychotics as opposed to the typical to limit the side effects. This table compares typical and atypical antipsychotics. The adverse effects of typical antipsychotics are extrapyramidal symptoms, and these are very common. In comparison, the atypical antipsychotics also have adverse effects of extrapyramidal symptoms, except they are very uncommon. Therefore, in an attempt to decrease our patient's hallucinations and delusions without the extrapyramidal side effects, the antipsychotic risperidone was used. The patient was administered a trial of the antipsychotic medication risperidone at a dose of 0.5 milligrams twice per day. Risperidone is a selective monoamine antagonist that has a specific affinity for serotonin and dopamine receptors, which should have helped our patient's delusions and hallucinations. Our patient did not experience any improvement when using risperidone, and this could be due to the already diminished number of serotonin and dopamine receptors. And although the patient was experiencing hallucinations and fixed delusions at the present time of the study, the patient's cognitive and motor functions were declining, but he remained semi-independent. We will now discuss the declining motor function, which is another symptom that could be treated in patients with dementia with Lewy bodies. Our patient did not receive any motor function improving drugs, but medications such as cholinesterase inhibitors could be helpful for other patients with this disease and other neurodegenerative diseases. A common example of this drug is donepezil. The cognitive, functional, and behavioral decline in patients with this disease is partially related to the cholinergic defects. The function of cholinesterase inhibitors is to inhibit acetylcholinesterase and prolong the time that acetylcholine is in the cell. The mechanism of action for inhibiting acetylcholinesterase is by having cholinesterase inhibitors attached to the serine hydroxyl group on the acetylcholinesterase, as shown in this figure by the nerve agent attaching to the serine hydroxyl group on the acetylcholinesterase. By the binding of this inhibitor, it blocks the acetylcholine from binding to the acetylcholinesterase and preventing the breakdown of acetylcholine. By doing this, there could be a potential increase in the motor function of patients with neurodegenerative diseases. The last point to be mentioned for a patient with dementia with Lewy bodies is to maintain a simple lifestyle. Being able to follow a consistent routine will allow the patient with dementia to continue to enjoy their interests, preferences, routines, as well as their physical needs. This can greatly impact the person's well-being and quality of life. Since the average length of survival for this patient is only about a year due to both the anaplastic astrocytoma and dementia with Lewy bodies, there should be ethical considerations discussed. Since dementia could cause a decrease in mental capacity, an evaluation of the patient's ability to make decisions should be determined. If the patient does not have a full understanding of the purpose of an invasive procedure, such as the radiation therapy, it could be seen as an assault of the patient. Also, any new drug that is added to the regimen, it may be difficult for the patient to follow instructions. A surrogate caregiver could be appointed in the event that the patient does not have the capacity to care for himself. The surrogate caregiver should be fully educated on the disease, treatment, and medication for both the anaplastic astrocytoma and dementia with Lewy bodies. Since the anaplastic astrocytoma has such a poor prognosis, it is advised that the patient have a durable power of attorney to make medical decisions if he loses the ability to make decisions for himself. An advance directive is also important for the future medical decisions in order to better understand what medical decisions he himself would have made. In this risk-benefit analysis, any potential harms may be clearly justified by potential benefits. This involves weighing the primary ethical principles of beneficence and non-maleficence. As stated before, our patient's cognitive and motor functions are declining, but he remains semi-independent. Therefore, a potential osteopathic manipulation treatment of muscle energy could be considered. According to the Foundation of Osteopathic Medicine, muscle energy techniques are thought to be especially helpful in treating patients with degenerative neurological disease. A combination of manipulation, physical therapy, and strength training in the earlier phases of neurodegenerative disease may improve head and neck posture, increase foot lift from floor, decrease incidence of falls, decrease depression, and thereby improving quality of life. However, muscle energy is contraindicated for uncooperative or unaware patients, so our patient's cooperativeness and understanding of the purpose of the OMG treatment should be taken into account. For patient education, patients with neurodegenerative disease should be informed of the importance of physical activity. Also, the patient should try and set a daily consistent routine. The patient should be informed of all drugs prescribed and their potential interactions. Finally, the patient should be monitored for any future decline in health or mental status. In conclusion, this case presents difficulties in diagnosing disease when there are many overlapping symptoms, specifically the symptoms of dementia with Lewy bodies, Parkinsonism, and the astrocytoma. In addition, treatment for this case was difficult due to the lack of suitable medications and low survival rate. Lastly, both the anaplastic astrocytoma and dementia with Lewy bodies demonstrated many ethical considerations in order to achieve the best quality of life and navigating the future health of this patient. We would like to thank all of the faculty and staff that shared both their time and knowledge on our case. We are now open for questions.
Very well done, student doctors. I know that we have questions. Is there a certain side that would like to begin?
So the question was, what is the mechanism/theory by which 18-fluorodeoxyglucose uptake shows a cancerous process on a PET scan? So in the PET scan, they administered 18-fluorodeoxyglucose, which is a glucose analog that undergoes the same uptake as glucose, but actually in neoplastic cells, it's trapped into those cells by phosphorylation by hexokinase. And so basically, this agent acts like a bait and is taken up in areas of metabolically active areas such as infections and tumors, and just to allow them to image it on a PET scan.
All right, we also had a question about tabes dorsalis, and this is a subset of neurosyphilis. It doesn't generally present until decades after infection. It's a slow degeneration of sensory nerve cells in the peripheral nervous system, and is characterized by a wide ataxic gait with a foot slap, dementia, peripheral neuropathy, Argyll-Robertson's pupils, which we saw in lecture, and the Romberg sign, which we saw in PCM lab last week.
So we had a question about neurosyphilis, and why would a person be unaware that they had syphilis? There's many categories for syphilis, and there's an asymptomatic category where they would be asymptomatic for even decades.
I had a question. Go ahead.
So we had a question, why did ubiquitin react with the Lewy bodies? So in our patient, he presented with large amount of these Lewy bodies in his brain, and which we said were aggregates of misfolded insoluble alpha-synuclein proteins. And these proteins are tagged by the ubiquitin, and which are markers for destruction by the cell. And because these these proteins are damaged and misfolded, they're degraded by the proteasomes, which are a complex of peptidases, and then the ubiquitin is recycled back into the cellular pool of ubiquitin.
I had a question regarding turning en bloc. Turning en bloc is a motor cortex problem typically associated with Parkinson's disease patients. So normally we twist our neck and our trunk and pivot on our toes to execute a turn. But when you turn en bloc, your neck and your trunk become rigid, and you have to take multiple steps to execute a turn. And this was exhibited in our patient.
All right, so this question's about amitriptyline. So it's a tricyclic or tertiary amine antidepressant. It acts primarily as a serotonin or epinephrine reuptake inhibitor, and it also works as a muscarinic acetylcholine receptor antagonist. So in her patient, it caused drowsiness and confusion, but some other side effects are anxiety, disorientation, and cognitive dysfunction.
We have time for one more question.
Another question we got was, what is graphesthesia? Graphesthesia is the ability to recognize writing on the skin purely by the sensation of touch. So to test it, you have the patient close their eyes and you trace a number or a letter on their skin and just see if they can identify the number or letter, and it tests cortical sensation.
Very well done. Again, thank you, student physicians. Let's go ahead and bring the next group up.
Good morning, and welcome to our Grand Rounds presentation. We are Group 28, presenting Case 37 from the New England Journal of Medicine, a 35-year-old woman with suspected mite infestation. These are the members of Group 28. And I am student Dr. Elizabeth Zach, and I'll be presenting our patient history and clinical presentation. A 35-year-old female with history of depression, hepatitis C, and drug dependency presents to the emergency department with a pruritic rash. Our patient had been in her usual health until 14 days prior to admission when she experienced increased insomnia, which she attributed to her loss of prescription Zolpidem. Zolpidem is usually indicated for the treatment of insomnia and anxiety. Beginning 10 days prior to admission, our patient began seeing white granular balls, which she thought were mites or larvae. She saw these mites emerging from and crawling on her skin, sheets, and clothing, as well as in her apartment, car, and feces. She noted an associated pruritic rash. She was seen by her primary care physician, who referred her to a dermatologist for follow-up of potential causes of pruritic rash. However, our patient did not make an appointment with a dermatologist at this time. 3 days prior to admission, our patient ran out of her prescription clonazepam and experienced increased insomnia and anxiety. This same day, she began seeing bugs emerging from the scalp of her 15-month-old son. The bugs were also present in his diaper and in his sputum. She proceeded to scratch both her skin and her son's skin to remove the offending bugs. 1 day prior to admission at this hospital, our patient called emergency medical services and was transported by ambulance to the emergency department of another hospital. A diagnosis of possible cheiloteilosis was made. This condition will be further discussed in our differential diagnosis section. She was discharged home with her son after being advised to use selenium sulfate shampoo and follow up with her primary care physician. On the morning of admission, the patient noted while bathing her son that his scalp was turning red, he was crying, and in visible distress. She presented with her son to the emergency department of this hospital, complaining of bugs crawling on her skin, which she attempted to point out to examiners. However, examiners were unable to see these bugs. Her past medical history includes hepatitis C, diagnosed 2 years prior, diverticulitis, nephrolithiasis, and acne since adolescence, with a described history of scratching and picking at her skin with an associated calming effect. 10 years prior, she had a facial abscess due to methicillin-resistant Staphylococcus aureus that was successfully treated. She also has a reported history of major depression, currently in remission. She denies associated symptoms of psychosis, including hallucinations and delusions during these times of depression. 4 years prior, she had a perforated duodenal ulcer that required surgical repair. She is currently taking buprenorphine and naloxone in combination, 8 milligrams sublingually twice daily, although 20 milligrams was prescribed. Buprenorphine is an opioid typically prescribed as an analgesic, and naloxone is typically prescribed in combination with an opioid to help prevent addiction. She was taking 150 milligrams of sertraline daily and ran out 2 days prior to admission. Sertraline is a selective serotonin reuptake inhibitor indicated for the treatment of depression. She was taking 0.5 milligrams of clonazepam 3 times per day and ran out 3 days prior to admission. Clonazepam is a benzodiazepine indicated for the treatment of panic disorder. She was also taking omeprazole of unknown dosage. Omeprazole is indicated for the treatment of ulcers or GERD. Our patient has no known drug allergies. She lives with her 15-month-old son, has been unemployed for 2 years, and receives transitional food assistance. She denies alcohol consumption. And although she has injected oxycodone in the past, she denies use since the birth of her 15-month-old son. She is dependent on sedative, hypnotic medications and opiates, including clonazepam and zolpidem. Our patient occasionally uses illicit amphetamine salts and reports having taken 60 milligrams in recent days. Her family history includes a maternal aunt who had schizophrenia, and her mother attempted suicide during the patient's childhood. On physical examination, our patient was cooperative, anxious, and disheveled. Vital signs were stable, although blood pressure and pulse were elevated. Excoriations were noted on the face, arms, and legs, although the mid-back was spared, and our patient readily indicated these areas to examiners. The image on the screen shows excoriations similar to what were found on our patient upon physical examination. However, these images are not from our patient. On mental status examination, our patient was fully oriented to person, place, and time. She became irritable and hostile with a female interviewer, but was pleasant and cooperative with a male interviewer. Our patient was convinced she had a parasitic infestation, believing she might have Morgellons, which she had read about on the internet. Morgellons is a condition in which patients describe an inorganic material, such as colored fibers or bugs, emerging from the skin in combination with cutaneous sensations. She pleaded with examiners for help and belief in her concerns. She reported no neurovegetative symptoms of depression, which include changes in sleep, appetite, energy, libido, and psychomotor activity other than the previously mentioned insomnia. Her thought process was described as perseverative, meaning she was unable to switch topics or focus on other topics besides the mite infestation, and she occasionally went on tangents throughout the interview. The patient's CBC, lipid panel, TSH, folate, and B12 values were normal. CMP revealed elevated levels of aspartate aminotransferase, an indicator of liver function, as well as hypophosphatemia. These are the results of the urinalysis. Both lab results and urinalysis are non-contributory and generally consistent with our patient's history of hepatitis C and nephrolithiasis. The HCG test was negative, however, her toxicology screen was positive for amphetamines. I would now like to introduce student Dr. Melanie Wolf to discuss our case's differential diagnosis.
Thank you, student Dr. Elizabeth Zach. I'm student Dr. Melanie Wolf, and I will be presenting the differential diagnosis. Just to recap, our patient has a firm belief that she's infested with parasites. She presents with excoriations on her face, arms, and legs, but the mid-back was spared. This is an important finding because it indicates that her excoriations were self-inflicted. In order to develop a thorough differential diagnosis, it's important that we consider both dermatologic and psychiatric aspects of our case. These are the dermatological differential diagnoses that we considered. The first infestation we considered is scabies. Scabies is caused by an infection of Sarcoptes scabii and is transmitted by direct contact with infected persons or by sharing objects containing the infectious organism. It presents as pruritic lesions in the circle of Hebra, areas of which include the wrists, web spaces between the fingers, antecubital fossa, axillae, umbilicus, groin, and genitalia. Lesions may be due to secondary to a hypersensitivity reaction to the organism, and diagnosis can be confirmed by the presence of mites, eggs, or fecal matter in a skin scraping sample. The second infestation we considered is cheilotiosis, which is caused by a non-burrowing mite called Cheilotella. It can be transmitted through direct contact with dogs, cats, or rabbits, which are animals that often carry these mites. It is also known as walking dandruff due to the white scaly appearance in addition to pruritic papules. Our patient's skin presentation was not consistent with either of these infestations, and upon dermatologic consultation, no organisms were identified. Thus, we were able to rule out both of these infestations. Our next differential was considered given our patient's history of hepatitis C, which is a possible cause of porphyria cutanea tarda. Porphyria cutanea tarda is caused by a defect in the heme biosynthetic pathway involving decreased activity levels of uroporphyrinogen decarboxylase, leading to increased levels of uroporphyrinogen 3. This molecule is photosensitive and undergoes chemical reactions that manifest as blisters and erosions on the dorsum of the hands, pruritus, as well as dyspigmentation, as you can see in this image here. Although our patient has a history of hepatitis C and presents with pruritus, her skin lesions were not consistent with that of porphyria cutanea tarda, so no further testing was pursued. We do not believe this to be a likely diagnosis for our patient. Systemic pruritus is a chronic itch secondary to a medical condition or medication and may be severe enough to disrupt sleep. A complete diagnostic workup should be performed to identify the underlying cause. In our case, the CBC, CMP, and thyroid function tests were unremarkable and would not account for our patient's presentation, so we were able to rule this out. Formication is a sensation of crawling, stinging, or biting and is considered a tactile hallucination. Patients often present with excoriations and erosions that are self-inflicted. These sensations can be idiopathic, neurologic, or drug-induced. Although our patient had confirmed amphetamine use and presents with these symptoms, formication is purely sensory and is not inclusive of visual hallucinations of bugs that our patient reported. We are now left with two differentials. Neurotic excoriations is a compulsive behavior in which patients have an uncontrollable desire to pick or scratch at their skin, usually at lesions or imperfections. This is consistent with our patient's presentation, as well as her history of picking at her acne. So far, neurotic excoriations cannot be ruled out. Because we have considered and ruled out all other reasonable dermatological etiologies, we arrived at delusional parasitosis as a possible diagnosis for our patient. In order to confirm this, we have to look at the psychiatric component. Patients with delusional parasitosis have a fixed belief that they are infested with parasites despite medical evidence to the contrary. This fixed belief despite evidence is the definition of delusional. Also, delusional parasitosis patients often suggest they have Morgellons, as our patient did. Another key feature of delusional parasitosis is matchbox sign, in which patients bring in samples that they believe containing the parasites, such as samples of skin or other materials. And although our patient did not bring in any samples, she did point out areas to examiners that she saw granules and bugs, and this can be equated to a positive matchbox sign and is indicative of her visual hallucinations. Delusional parasitosis has three potential causes, including non-psychogenic entities, primary psychosis, and secondary psychosis. It's critical to determine which one of these is the underlying cause of our patient's symptoms. Non-psychogenic entities include undifferentiated somatoform disorder and hypochondriasis. Undifferentiated somatoform disorder is one or more physical symptoms that cannot be explained and persists for more than 6 months. Hypochondriasis is the fear of having a serious disease based on misinterpretation of normal bodily symptoms as abnormal. We can rule out non-psychogenic entities due to the fact that our patient is delusional, whereas non-psychotic patients are not delusional. In addition, our patient had an acute onset, which does not match this etiology. Now we have to consider primary psychosis, which includes schizophrenia, major depressive disorder, and bipolar disorder. Primary psychosis is the presence of psychotic symptoms that cannot be attributable to substance use or another medical condition. These symptoms also usually persist for more than 6 months. We must also consider secondary psychosis, which is psychosis attributable to a medical condition or substance use. We believe our patient's diagnosis is due to secondary psychosis and not primary psychosis due to the acute onset and positive toxic screening for amphetamines. Since her mental status exam and lab values were unremarkable, we can rule out an underlying medical condition as the cause, leaving us with substance-induced secondary psychosis. Substance-induced secondary psychosis can be due to withdrawal from substances such as alcohol, opioids, and sometimes medications, or intoxication from substances such as amphetamines, cocaine, or hallucinogens. Because our patient had an elevated blood pressure, was irritable and restless, and had a history of opioid use, we cannot completely rule out withdrawal. However, we believe the most likely cause is due to intoxication because of the positive toxic screening for amphetamines, and our patient had no sign of tremor, which is a common withdrawal symptom. For this diagnosis, it is important to understand the mechanism of amphetamine intoxication in the CNS. Figure A demonstrates the normal reuptake and storage of neurotransmitters. Dopamine, norepinephrine, epinephrine, and serotonin are synthesized and stored in cytoplasmic vesicles of presynaptic neurons. Figure B illustrates how amphetamines can diffuse into the neurons and vesicles, displacing the neurotransmitters into the cytoplasm where they diffuse into the synapse. Here they accumulate and they activate postsynaptic neurons. Stimulants such as amphetamines can also inhibit the reuptake system of these neurotransmitters, therefore causing prolonged activation of their receptors, shown here in Figure C. Adrenergic stimulation results in hypertension, tachycardia, hyperthermia, and vasospasm. Serotonergic stimulation is involved in mood alterations as well as hunger and thirst. Dopaminergic stimulation can result in drug craving or seeking behaviors as well as psychiatric symptoms. For our patient, it was delusion. Overstimulation of all of these receptors can result in psychosis, which in our case presented as somatic delusions with visual and tactile hallucinations. Unfortunately, because our patient has other underlying drug issues and is potentially experiencing withdrawal from clonazepam, zolpidem, and sertraline, we cannot conclude that amphetamines solely induced her delusional parasitosis. It is possible that other drug issues can exacerbate or even contribute to her symptoms. Toxic screening could also give a false positive, as amphetamines can be detected 2 days after administration. In addition, given our patient's family history of mental illness, primary psychosis cannot be completely ruled out. Currently, our working diagnosis is amphetamine-induced delusional parasitosis. This can only be confirmed after treatment. Let me remind you that our patient also exhibits neurotic excoriations, which we believe is habitual and not associated with her psychosis. I'd now like to introduce student Dr. Tyler Jorgensen to present the treatment and ethical implications.
Thank you, student Dr. Melanie Wolf. My name is student Dr. Tyler Jorgensen, and I will be presenting the treatment and ethical implications of our case. To recap, we were able to narrow down our diagnosis into either primary delusional parasitosis in addition to amphetamine usage, or delusional parasitosis secondary to amphetamine usage. Fortunately, both possibilities have identical acute treatment, namely amphetamine usage cessation and antipsychotic medication. Antipsychotics are commonly prescribed in cases of psychosis, such as schizophrenia and mood disorders. There are two main drug treatment types: first generation or typical antipsychotics, also often referred to in the literature simply as antipsychotics or AP, and second generation or atypical antipsychotics, SGA. I'll briefly describe these drugs and also provide an illustration of their mechanism. First-generation antipsychotics, such as pimezoi, work by blocking D2 dopamine receptors in the limbic system and striatum. Possible side effects include hyperprolactinemia, tremors, bradykinesia, and even sudden death. Second-generation antipsychotics, on the other hand, such as risperidone, work by blocking both dopamine and serotonin receptors in the striatum and cortex. It's important to note that second-generation antipsychotics are associated with a reduced degree of negative side effects when compared with first-generation antipsychotics. This figure illustrates the primary differences in the mechanisms of first-generation and second-generation antipsychotics, which lend to the differences in the severity of their respective side effects. As you can see here, a first-generation antipsychotic, represented here by pimezide, binds tightly to its associated receptor and has a slow turnover rate. This prolonged inhibition has a greater likelihood of leading to severe symptoms. On the other hand, a second-generation antipsychotic, represented here by risperidone, binds with less affinity to its receptor and has a quicker turnover rate. This decreased inhibition is relatively less likely to lead to severe side effects. Research concerning the treatment of psychosis is limited due to its complex and multi-etiological nature. However, one case in 2008 provides quantitative data through a retrospective study of 63 cases, which describes the efficacy and outcome of using second-generation antipsychotics in treating primary and secondary psychosis. Risperidone and olanzapine were preferentially used in this study and showed an effectiveness of 69%. Currently, there is no definitive research indicating the use of osteopathic manipulative medicine for the treatment of delusional parasitosis. Our patient was admitted to the psychiatric unit, and treatment was begun through an amphetamine washout period and a prescription of risperidone at 2 milligrams per day. In addition, our patient's dermatologist also suggested adding acute management of our patient's pruritic rash through bandaging her hands and cutting her fingernails. As a result of treatment, our patient's delusions resolved within several days. She was also eventually able to articulate that her symptoms were a result of her drug use. She was discharged and given a prescription of risperidone and clonazepam, as well as was referred to the Body Dysmorphic Disorder Clinic for cognitive behavioral therapy. Cognitive behavioral therapy, or CBT, is utilized in the long-term management of numerous psychiatric conditions. Psychiatrists assist patients in understanding the connections between the problematic thoughts, emotions, and behaviors of their conditions. The goal of CBT is to reduce the impact of delusions, thereby improving treatment adherence as well as reducing future substance abuse. Although our patient's CBT attendance was erratic, she was successfully able to return to work or school, and her use of office-based opioid treatments allowed her to avoid substance abuse since the time of her treatment. Due to the elimination of our patient's visual and sensory hallucinations upon cessation of amphetamine usage, we were able to determine that her delusional parasitosis was most probably caused by a substance-induced secondary psychosis. Therefore, the final diagnosis of our patient was amphetamine-induced psychosis with delusional parasitosis and neurotic excoriations. This refers to the habitual scratching also exhibited by our patient. It is important to note, however, that our patient's family history of mental illness may also have been a contributing factor in her condition and cannot entirely be ruled out. In addition, the effects of withdrawal of our patient's previous prescriptions prior to admission may also have been exacerbating her symptoms. There are several ethical and legal considerations that should be remembered when considering our case. First, when approaching the treatment of a patient with suspected delusional parasitosis, it is important for physicians to remember the incumbency to honestly investigate and rule out an infestation as the primary cause for the patient's symptoms. Second, it is imperative that physicians treat in a way to maintain therapeutic rapport and trust without reaffirming the patient's delusions through useless and extreme treatments. These 2 points were observed in our case through a good faith effort to provide a comprehensive approach and avoid an immediate diagnosis of exclusion. Third, it is important to remember that in order to respect the patient's autonomy, treatment must not be administered until after informed consent has been received. Obtaining such consent in cases of psychosis can often be difficult, because it entails persuading patients to accept treatment that does not initially correspond with their beliefs concerning their symptoms. However, if capacity is determined and a full disclosure of information is given, informed consent can still be obtained. In this particular case, our patient was capable of understanding her diagnosis and voluntarily accepted psychiatric treatment on rational terms after receiving the promise of a future dermatological consultation. Another important consideration in cases of psychosis is the safety of the patient and of the patient's associates. In the state of Massachusetts, if patients pose serious risk to either themselves or to others, they can be contained within psychiatric care for observation and treatment. This is called an emergency hold and can last up to 3 business days without a court order. However, in our case, because our patient did not pose a serious immediate threat, but was rather seeking medical treatment, an emergency hold was deemed unnecessary. Special attention must also be given to several concerning factors regarding the safety of our patient's child. It is first important to remember that physicians are mandated reporters in situations where a child's safety is questioned. Such was the condition of our case, and the Department of Children and Families was subsequently involved. Among the important factors of note concerning the safety of the child was our patient's personal history of drug abuse, as well as the unknown circumstances surrounding a possible transmission of her MRSA to her son. Munchausen by proxy syndrome, where a patient will deliberately fake evidence of a child's illness through harm, is also another consideration in cases such as ours. Yet despite these factors, there is no credible basis to believe that our patient was deliberately harming her son, especially considering that she promptly sought medical attention upon seeing his distress. Since the time of treatment, the Department of Children and Families has been working with her to help improve her home and family environment. She is presently showing hopeful success and is determined to continue her progress, primarily due to a strong desire to provide an optimal future for her son. As a final consideration, providers must be especially careful when prescribing medications that can be easily abused to patients with past history of substance abuse. In our case, for example, re-prescribing clonazepam, a potentially habit-forming medication, may not have been a wise choice, considering our patient's history of addiction. To build upon the challenges faced within our case, our group proposes a series of recommendations. First, when available and appropriate, conditions such as delusional parasitosis ought to be handled by using a collaborative effort between dermatology and psychiatry departments. Second, an effort should be made to keep physicians continually aware of cases such as delusional parasitosis through continuing medical education, so as to decrease the time of final diagnosis and improve patient outcomes. Third, measures should also be taken to assure general education of the public concerning the dangers of substance abuse and the delusions that can result from it. We would like to thank the following faculty for their support and assistance in creating this presentation. These are our references, and we are now open for questions.
Excellent work. I know that we have questions. Which side would like to start?
Sorry, is this on? Yeah, okay. So we had a question about hallucinations associated with amphetamine use, and if there have been any fMRIs done to show the areas activated by amphetamine use. So I did find a study dealing with amphetamine use for adult ADHD patients, and they found that the left dorsolateral prefrontal cortex and the medial prefrontal cortex were activated by amphetamine use treatment. But I haven't been able to find any recreational use of amphetamine use like in our patient.
We got a question about what are the negative side effects of prescribing opioids with antidepressant medications. So opioids and both opioids, such as cocaine or amphetamine, and antidepressant medications do inhibit MAO inhibitors. I mean, they act as MAO inhibitors, and also they decrease the uptakes of monoamine neurotransmitters. So they can both induce a surge of norepinephrine or dopamine activation. So they can actually aggravate the condition of the patient, so that induces psychosis, such as our patient.
Another question that we got was, what does selenium sulfide shampoo do? So selenium sulfide is used for the treatment of seborrheic dermatitis, which is dandruff of the scalp, as well as tinea versicolor, which is a yeast overgrowth on the skin. It's also used as an antifungal medication as well for organisms such as microsporum and trichophyton.
All right, so we got a question on what is the physiology of extrapyramidal side effects. As Tyler mentioned, extrapyramidal side effects include motion disorders such as dystonia and bradykinesia, and it refers to neural anatomical tracts that control voluntary motion. In particular, it focuses on two pathways in basal ganglia, the direct pathway, which allows motion when activated, and the indirect pathway, which inhibits motion when activated. Dopamine binding to D1 receptors activates the direct pathway, and dopamine binding to D2 receptors inhibits the indirect pathway. Typical antipsychotics block D2 more so than D1, which results in the indirect pathway not being inhibited as much as it should be, and the direct pathway not being activated as much as it should be, which leads to slow or inappropriate movements.
All right, this question asked, what is the difference between a psychogenic disorder and an organic mental disorder? So an organic mental disorder is one that arises because of a physical or a medical condition, and a psychogenic one arises because of emotional or mental stressors. It's usually associated with a psychiatric condition.
All right, so unfortunately I forgot to ask the first group, but can you think of 3 take-home points that you would like your audience to derive from your presentation?
For the first point, in a multifaceted case such as ours, it's important to have a strong communication between the different specialties, such as in our case, the primary care physician, the dermatologist, and the psychologist. Secondly, transparency and honesty present a unique challenge with any delusional disorder in obtaining informed consent. In the third, in a psych case, it's especially imperative for follow-up, not only for the patient's health and safety, but such as in our case, for the child's health and safety.
Excellent job, student doctors. Thank you so much for being here for our Grand Rounds presentation, and thank you to our online viewers. Have a wonderful rest of your day.